Dengar kan?
Dengar doktor.
Dengar doktor.
Okay, kita mula kita Al-Fatihah. Okay, boleh start.
Yeah, so Bismillahirrahmanirrahim. So, welcome to our Prognosis seminar supervised by Dr. Alwi. So today altogether we have two presenters. So first we begin with my topic, which is the child with altered consciousness, followed by child with joint pain, and then child with prolonged fever. So first we'll go to my part. So Bismillah. Okay, so my name is Hanani. My metric number is 1610154. So I'll present on child with altered consciousness. So next. So I'm sorry for the slide. And anyway, for the altered consciousness, so basically what is consciousness? So consciousness it represents awareness of the self of environment. So when someone is said to be altered in consciousness, there is actually some spectrum in it. So it will start with the mildest form and it can become to a much severe form, which is the coma state. So it starts with the mildest form, which is the clouding of consciousness, in which the patient starts having inattention and also reducing wakefulness. And then it will follow with confusion, in which the patient starts to having disorientation, and then lethargy, in which the patient they experience drowsiness, but they can still be aroused with modern stimuli. But in the case of obtundation, the patient start to have decreased duration of being awake, and they respond slower to the stimuli as compared to the lethargy. And in the case of stupor, in this case, the patient they will only become aware in the state of wakefulness if they respond to the pain, but not any other stimuli. But in the case of coma, which is the severest form of altered consciousnness, they is in a state of unresponsiveness that cannot be aroused, no matter how large the stimuli is. So this is what the altered consciousness spectrum is. So it's important for us to detect whether the child is having altered consciousness, because altered consciousness is actually an emergency. So sometimes in child, they may present with irritability. With irritability also indicate the patient may have altered consciousness. So next. So according to the PITS protocol, this is how we can approach to a child that have altered consciousness. So I will go one by one to the step. So first, next, you start with the initial assessment. So because the most case of long-term morbidity in patients with depressed consciousness is hypoxia. So it's important for us to address the airway, breathing, and also circulation first. So in airway, so we need to ensure that the airway is secure. And then for the breathing, we need to give adequate oxygenation. We may need to give artificial ventilation if required. And then for circulation, we need to give IV bolus and also the inotox and chest compression depending on the condition of the patient. And then it is important for us to check the blood glucose level, because hypoglycemia is among the causes of altered consciousness, and this condition it can be fixed rapidly if we just take the time to check the dextrose, and then we take the hypoglycemia. And then once patient is stabilized, we need to monitor the vital signs, including the SpO2 and also the urea output. So next we go to the next step. Is we need to assess the Glasgow Coma Scale of the patient. So similar to adult, we also assess the EVM, which is the eye opening, the verbal and also motor, and also the total score for GCS for children, and also is similar to adult, which is 15. However, you can see that for the best verbal and also the motor part, there is a bit different and how we can assess for those who are younger than 1 year old, because their speech may not be comprehensible yet. So instead of we assess whether the patient is having oriented verbal speech, we may need, they are maybe having poor or babbles, meaning that in the usual situation. And then if it's confused, the patient may be irritable, or they may be, for the inappropriate word, maybe in the case of infant, they may have to try to pain. And then for the non-specific sound in adult is similar to infant, they are moaning to the pain. Or if then in the non-case, it's the same, meaning that the child is silent, with them, they are not making any sound. And then for the motor part, for the infant is also a bit different. You can read in the table. So how after determining the Glasgow Coma Scale, so we total up the score. If the total score is more than 12, we need to monitor the Glasgow Coma Scale hourly. However, if it's less than 12, we need to monitor it more frequently, which is half an hour until it improves. So next, the next step. So we also need to consider when we need to intubate the patient. So because the aim of intubation is to ensure the airway is patterned. So when do we need to intubate the patient is for there are altogether 7 conditions, which is the first one is if the airway, it is not supported, the airway will be obstructed, or the airway is compromised due to the vomiting. Or for the third one is the respiratory rate is too low for adequate ventilation. That's why we need to give intubate. And then if the SpO2 remain less than 92%, even though we already give high flow oxygen and airway opening or maneuver has already been done. And then and the next one is there is still sign of shock even after we already give adequate fluid resuscitation. And the next one is there is sign of exhaustion. And the last one is Glasgow Coma Scale is less than 8 and it's deteriorating. So this is the condition that we need to intubate the patient. So next. So the next step is we need to look for whether the patient has any seizure, shock, sepsis, or any sign of rest intracranial pressure, and then we need to treat them. So for this one, I'll focus mainly on how to detect the rest intracranial pressure because this is very common in patients with altered consciousness. So how we can know whether the patient has rest intracranial pressure is either the patient has papillary edema, or if we cannot assess for papillary edema or we do not detect any papillary edema, the patient may fulfill any 2 of the 5 conditions. So the first one is based on the Glasgow Coma Scale is less than 8, or there is unreactive or unequal pupil. So unreactive pupil is basically when we directed the light to the pupil, we expected the pupil to constrict. However, the pupil doesn't show any reaction. So that is when we consider the pupil is unreactive. So for the abnormal dot eye reflex, decorticate, and also abnormal breathing, I'll spend on the next slide. So next. So this is just a picture on the unequal pupil, meaning that one side is constricted while another one is dilated. So next is for the dot eye reflex. So dot eye reflex is basically this maneuver. We can only assess them in patients that are comatose or the newborn. So how we can assess this maneuver is that if we move the head to one side, we expected the eye to move to the other side. So like you can see in the picture, if we move it to the right, we expected the eye to move to the left. So this is if the patient show this condition, it means that the vestibular ocular patu is intact. However, if the eye move the same direction with the head, meaning there is interrupted. So this also indicates there is rest in intracranial pressure. So why this condition can only be assessed in comatose or newborn is that in awake patient or in older patient like us, if we tend to have we can do it voluntarily, follow our head to the same side. So this will must be reflect. So that's why we cannot assess this in older or awake patient. So next is on the decorticate and also decelerate posturing. So the decorticate and also the decorticate position is actually due to the bilateral cortical and also subcortical abnormality. So there is, however, there is still intact in the brainstem function. So you can see that in the picture, there is rigidity and rigid extension of the leg, but the arm is in flexion position and the hand is twisting. This is differ from the decelerate in which the legs is similar, they are both in extension. However, the arm is in extension position. So the arm position is what differ the decorticate and also decelerate. So in decelerate, the brainstem is the function of brainstem is impaired, in which because of there is mid-brain anomaly. So how, just a way to remember which. So you can see that the arm to the core, meaning that the arm is held in flexion, is decorticate. So arm to the core, decorticate. That's how we can remember it. So next. So another indication of rest in ICP is the presence of abnormal breathing. So the example in the fixed protocol, it gives the chest stop breathing pattern and also the apnea state. So the chest stop breathing pattern is actually there is alternate in hyperapnea and also apnea stage. While apnea state is there, as you can see, there is prolonged inspirator phase followed by a phase prolonged pause at the end of inspiration. So you can see the in the table how it differs from the normal respiration one. So just to recap, the sign of rest ICP is the presence of papillary edema or 2 out of the 5, which include the Glasgow Common Scale less than 8, the unequal unreactive pupil, the abnormal dull sign, and the decorticate at the abnormal posture and also the abnormal breathing. So it is important for us to detect this sign because we need to add on it later on in the management part. So next. So next is on the etiology. So there is actually many causes of altered consciousness. So the one in the left is actually the listed one in the fixed protocol. So it's actually the important one, which is the all the CNS infection, including the meningitis and also the brain abscess, and also the trauma, vasculitis, acute poisoning, and then the metabolic disease. And also in all cases, it's important for us to consider the non-accidental injury. And then they can also be due to ADEM, and then also stroke and also hydrocephalus. So because when we want to approach the patient for the history and also the physical examination, we need to find the one that considered as pathology, but the causes is so many, right? So that's why maybe we can use some mnemonic just to add our memory so that we doesn't miss any important etiology. So the mnemonic that I can share with you guys is the TIPS 8IOU. So the TIPS 8IOU, they stand for T for trauma or tumor, and then I for infection, and then P for poisoning and also psychiatric problem. And then S is for sepsis or the subarenal hemorrhage. And then A is for ammonia or abuse. Abuse is the non-accidental injury. And then E is endocrine and also epilepsy. And then I, insulin, it may be due to hypo or hypoglycemia. And then O is hypoxia. And then U is for uremia. So by using this etiology, maybe we can go for the history and also the physical examination. So next. So for the history, so what we should ask the parent if the child is having altered consciousness. So it is important for us to assess the onset of the symptom because different etiology has different onset. For example, if the onset is sudden, we may worry about the intracranial hemorrhage and also epilepsy and also trauma. However, if the onset is a bit gradual, it may be infection or metabolic derangement or stress of violation. And then regarding the associated symptoms, it actually depends on what etiology that we are worrying about. So if we are worrying about infection, so we need to ask about fever or seizure. And then for the most of the symptom here is about the meningitis one, which include the neck stiffness, photophobia, and also because we also need to know the symptom of increased ICP based on the history. And then we also need to ask for any history of the recent trauma to the head, and then possible ingestion of exposure to medication or toxin because this is part of the etiology one. And then we also need to know whether the patient is actually has any underlying disease because, like for example, if the patient is having diabetes mellitus type 1, we are worried that this altered consciousness is maybe due to DKA. And then so we also maybe need to ask about family history of malignancy if you are worried about tumors, breast occlusion, and then the consanguinity if in the case of inborn error metabolism. And maybe we can ask whether this patient is went for nursery because maybe this has increased risk for infection. So next. So next is physical examination. So we need to look at the patient general appearance and also we do the neurological examination. So for appearance wise, if the patient is having infection, they may have toxic looking or they are present of rash. So the jaundice one, if we are worrying about hepatic encephalopathy, and then maybe evidence of trauma such as having bruises that can indicate the predisposed to the altered consciousness. And then for the head, because we are worried about hydrocephalus, so we need to look at the size, whether they are obviously disproportionately large, the presence of dilated vein, and then we also need to look for, in the case of younger patient that the anterior fontanelle has not fused yet, there may be bulging of the fontanelle, they indicate increase in the ICP. So, and then for the eye, there is unreactive or incompatible, which I explained before, that is due to the ICP. And then sun-setting eyes is actually related to the hydrocephalus. And then papular edema, so the papular edema and also retinal hemorrhage is we need to do the direct ophthalmoscopy. So for papular edema is for ICP and also retinal hemorrhage if we suspect for non-accidental injury. And then for breast, maybe there is different order in the case of DKA or maybe toxic injection. And then because we are worried about meningitis, maybe we need to elicit for the clinics and also Budzinski sign. And then for vital sign, actually it's depend on the causes. So you can read it there, but just to highlight on if the patient is having rest in ICP, so we expect to have the Cushing triad, which is there will be hypertension, bradycardia. Oh, sorry, doctor. So for if in case of the Cushing triad, it include the hypertension, bradycardia, and also the bradypnea. So if we are worried about the increased ICP, this is the vital sign that we will look for. So next. So this is the list of investigation that we should do because we need to determine the etiology. So what we can do is we can do the FBC. We can look at the leukocytosis and the differential if we are worried about infection. And then we also need to do the urea and also the electrolyte for the electrolyte. And then we also do the blood for if you are worried about hypoglycemia or maybe DKA. And then for the liver function test, okay, for the hepatic encephalopathy, and then serum ammonia for the hyperammonemia, blood gases for the acid-base imbalance and also DKA. So with DKA, we look at the iron gap. And then blood culture, if based on the FBC that we see there is sign of infection, so we can do the blood culture later on for the management for antibiotic. And maybe if we are worried about DKA, we can look at the urine analysis to look at the level of ketone for the ketonuria. And then that is for the recommendation blood investigation and also the urine. And then for all the patients that have increase in ICP, we need to do urgent CT or MRI brain if the patient, once the patient is stable. And for the lumbar puncture, we need to delay it until we get the CT scan because we are worried of if we do lumbar puncture, in the case of rest in ICP, that will lead to herniation, the brain herniation later on. So, and then there is the other optional, the list of optional investigation. This is if we are we do this optional investigation depending on our suspicious of the certain disease. If, like for example, if we are worried about malaria, maybe we can do the blood film malaria picture, but that is optional. Okay, so next. So this just basically a list of causes paired with history and also the diagnostic investigation for the altered conscious level. So I will not go through this because I have like summarized all in my previous slide. So next. Okay, so we went to the last step of in the case of altered conscious level is the management. So basically, the goal of management is first we need to stabilize the patient, and then we need to treat it according to the cause. That's why it's important for us to determine the etiology first. So for my part, I will explain on the management of the increased ICP. Okay. So how we manage increased ICP is the first one is nursing. On the nursing part, we need to put up the bed 15 to 30 degree position because we need to improve the venous drainage and also we need to position the head in the midline. And for the ventilation, we need to ensure good oxygenation, ensure adequate sedation and also analgesic. And then for the fluid and electrolyte balance, we need to keep the patient hydrated, but we need to avoid the hypoosmolar fluids, example the pen desktop solution. Why? Because this solution, it will increase further the ICP level, so they will exacerbate the patient condition. And then we need to maintain the cerebral blood flow. We need to keep the cerebral perfusion pressure more than 50 millimeter mercury. And then we need to give the hypoosmolar therapy. This hypoosmolar therapy will help to reduce the ICP level. So we can either give IV mannitol or hypertonic saline. And then surgical decompression, it may be indicated if the medical measure fail. So next. Okay, so this the final part of my presentation, which is the outcome. So it just said that the outcome of patient child with altered conscious level is depend on the underlying cause. But it said that 1/3 may not survive, and 1/3 will recover, but they have long-term side effect with deficit. But 1/3 they may recover completely, and then the acute complication that the patient have, it may improve with time. An example of the acute complication may be motor deficit or cortical blindness. So this is all for my part. Next is the next slide is my reference. Sorry, I didn't realize I was going too fast. Do you guys have any questions?
I have a question.
Yes.
Okay, so how do we ensure that cerebral blood flow CPP more than 50 millimeter mercury? as you mentioned in the management slide?
Actually, the CPP is measured based on the how we measure CPP is MAP minus the ICP level. So if we want to ensure that the CPP is less than 50 millimeters, we need to reduce the ICP level. So how we can reduce the ICP level is by using the hyperosmolar therapy.
Okay, thank you.
Which one easier? That's a very good question lah. CPP more than 50. How do we actually monitor the ICP or CPP?
By using the central line, betul?
Central line untuk measure apa? Central line. Central line untuk measure apa?
To IG. I'm sorry, Doctor, I'm not sure.
Yeah, you need invasive monitoring lah. You have to insert what you call it, I can't remember the name. It's either you do LP, use manometer, ataupun you measure the intracranial pressure using device lah, through Omaya ataupun shunt. But usually kan, because the formula is, what is the formula again? MAP minus?
MAP minus ICP.
Equals to CPP kan? No? Kan? Hello?
Betul doktor.
Kan? So because the aim is we want to reduce the ICP. Okay? The aim is we want to reduce the ICP. So besides how to reduce the ICP, one, you can use hyperosmolar therapy lah to reduce the edema. Besides that, what can you do? What can you do to maintain the CPP? CPP ni apa? CPP?
CPP is cerebral perfusion pressure.
It's cerebral perfusion now. So you want to maintain the cerebral perfusion more than 50. You want to maintain the perfusion. You tahu Kenley Monroe doctrine tak? Kelly Monroe doctrine.
The one that about the cow tissue and also the
Because you have to understand that's doctrine lah. That doctrine baru you can understand what is CPP, what is ICP. So in general, in Kelly Monroe doctrine, because brain, the skull is a closed system kan. So the pressure is fixed. Okay, the pressure in the skull is fixed, and it's contributed by the three elements in the skull. What are the three elements? What are the three components of the skull content?
Brain, blood.
Brain tissue kan. First is the parenchyma tissue, and then the blood, and the third one is CSF kan. So you've got there's only three components in the brain. Okay, so you've got cerebral edema. Okay, so you've got volume expanded. The volume of the parenchyma is expanded, so it will compromise the CSF and also the blood kan. Okay, bila you compromise the blood, so you got ischemia of the brain. So in order to maintain the perfusion of the blood, you have to reduce the brain punya volume tu lah. You have to reduce the volume, the edema. So by using hyperosmolar therapy. But what else you can do? You can increase the BP, betul tak? By increasing the BP, you increase the ICP, so you will increase the CPP. Faham tak? You guys faham tak?
Faham doktor, faham.
You jawab lah. Bila tak jawab, I tak tahu.
Macam
Okay, faham kan?
Increase the blood pressure will increase the ICP.
Increase blood pressure will increase the CPP because the formula is MAP minus ICP equals to CPP. Betul tak?
Betul.
Now, so your strategy now, because you want to keep the CPP as high as possible, So your strategy now is by reducing the ICP ataupun increasing the MAP. Faham tak?
Faham.
Okay, so in that way, in general, acutely, you can increase the BP to make sure the BP can overcome the ICP so that it maintain the CPP. Faham tak? While waiting for the hyperosmolar therapy to work, or in some cases while waiting for surgical decompression, you have to maintain the BP as high as possible. Usually we want the MAP for children at least, it depends on the age lah, but usually at least around 70 or 80, things like that lah, around there, to maintain the CPP. Okay, because what is the normal ICP?
10 to 20.
About 10 to 20 lah kan, biasa plus. So you want to keep that way lah. So kalau you ada cerebral edema, so your ICP increase to 30, to maintain the CPP of 50, you kena make sure MAP you more than 80 lah kan. Because 80 minus 30 is 50. Okay, faham tak?
Faham.
Okay. Okay, ada soalan? Lagi? That's very good questions. You guys dah buat NS punya place posting kan? Okay. Okay, then you should be good lah. Okay, lagi soalan?
So doktor, jadi macam mana
Siapa
kita increase MAP tu?
So you maintain the BP lah. Macam nak maintain BP?
Di vasoconstricted.
By inotropes ke?
Oh,
By fluid lah, by fluid. Okay, you've mentioned about hypoosmolar kan? Okay, what contribute your osmolality?
The sodium, doktor.
Sodium lagi? What else? Contribute your osmolality. How you calculate your osmolality? Sampai tadi soal search lah. Search lah kat internet. You guys kan ada internet. How you measure the osmolality? How you calculate the osmolality? It's very important, especially in the treatment of HSS. Even DKA pun is very important. In cerebral edema, of course, important. Okay. So macam mana you measure osmolality? Sodium, urea and glucose kan? Okay. So you need to give a hyperosmolar untuk reduce the blood cerebral edema, and you maintain with normal osmolar lah. You cannot give hypoosmolar. What happen if you give dextrose contain sugar? Because got dextrose contain solution. Kalau you bagi 50% dextrose, you rasa osmolality dia high tak? 50% dextrose.
High
kan? So boleh tak you bagi 50% dextrose? Kan treatment dia hyperosmolar kan? Can you give 50% dextrose? Okay, you can. Okay, because dextrose ni you bagi je, your tissue will utilize the dextrose. So memang you masuk 50%. So initially memang it's hyperosmolar. Tapi once it's enter the blood circulation, all the tissue will use up the glucose. What will left? It's a plain water. So kalau you bagi plain water, it's very hyperosmolar, you dapat cerebral edema. In fact, kalau you ada patient yang normal kan, normal patient pun, you just bagi 50% dextrose for maintenance, after a while patient tu koma. So you bagi a lot of diluted fluid kan, just plain fluid. So you akan dapat hyponatremia, and then you drop the hypoosmolar, so you get cerebral edema semula. Anyway, so next question, ada question lain ke? Any questions? Tadi I ada few questions, tapi pasal I dah ngantuk sangat, I dah terlupa dah all the questions. Ya, ada soalan?
Tak ada.
Okay, tak ada, move to next one. We got two je kan?
We have 3 presenters.
Lemak teli Okay lah, quick lah.
Saya buat laju-laju, doktor.
Okay, good. So I rasa you guys will baca je benda ni.
Ha.
You stress on points yang you rasa something yang novel atau something yang striking lah, yang orang tak cannot get from book. Macam tu. Please.
Okay, doktor.
Yeah.
Okay, so Assalamualaikum warahmatullahi wabarakatuh. So today I'll be presenting on joint pain. Okay, so next. So joint pain is also known as arthralgia, in which it means that there is a joint pain without swelling, which differs it from arthritis, which is defined by intra-articular swelling or two or more of the following signs. Either there is a limitation in the range of motion, tenderness or pain on motion, or there is warmness at the joint. Okay, so next. So the etiologies for joint pain differs. Is the slide already moving? Because mine is stuck.
Yes. Etiologies.
Okay, so the etiologies for joint pain differs for monoarthritis and polyarthritis. So monoarthritis means it involves only one joint, while oligoarthritis meaning it involves 2 to 5 joints, and polyarthritis is more than 5 joints. Okay, so for monoarthritis, you need to first think of infection-related causes such as septic arthritis, osteomyelitis, and so on. And also think of trauma, which can be due to fracture or foreign body, and then malignancy, inflammation, as well as hematorosis. Okay, so next. For polyarthritis, it can also be infection related, such as from Neisseria gonorrhea infection, viral infection. However, I think usually we encounter inflammatory causes such as JIA, SLE, juvenile dermatomyositis, and so on. We need to also suspect malignancy, mechanical, and other systemic illness when the patient comes with polyarthritis. Next. Right, so in the history taking, the onset of the pain is important, in which it gives you an idea of the diagnosis in your head. So it can be divided into 3. For acute arthritis means less than 6 weeks, subacute means it's about 6 weeks, and chronic is more than 6 weeks. So for acute arthritis, you can suspect trauma, HSP, acute rheumatic fever. Subacute is more like reactive arthritis, SLE, while chronic is JIA, psoriasis. Okay. So regarding the pain, you also need to know about the site, the number of joints involved, severity, the frequency, duration, the pattern, and the associated symptoms, such as if there is any skin discoloration or warmness. And if it is accompanied by morning stiffness, it is usually a feature of inflammatory arthritis. While night pain can occur in malignancy or osteoma, and pain that worsen on activity is usually due to destructive joint pain. And fleeting pain, which means migratory arthritis, means the it moves from one joint to another joint. It usually can be seen in acute rheumatic fever. Okay, so next, it is also important to ask if the patient have fever, and the pattern of fever. If it is high grade fever with chills and joint swelling, it's usually is due to septic arthritis, while long-standing low-grade and continuous fever can be seen in tuberculosis. Prolonged high-grade regular fever can be seen in SLE and idiopathic arthritis, while prolonged fever with joint involvement can also occur in leukemia, in malignancy. Okay, so next, we also need to ask the patient regarding the preceding event before the arthritis, such as if there is any infection in which can occur in acute rheumatic fever, arthritis, in Rett syndrome, GI symptoms in IBD, if there is any viral infection, and recent immunization is also important, such as for septic arthritis patient. it can be due to HIV. So you need to ask about immunization. And then trauma. Drug is also important. Also ask for sexual activity, which can be the cause for septic arthritis, and traveling history, such as in Lyme disease and TB. Okay, so next, for family history, some of the disease that involve joint also can be genetic. Wait. Oh, is it? Okay, sorry. It's bleeding blood disorder. Okay. Yeah, some of the joint diseases involve can be due to blood disorders. So we need to ask patient if there's any gum bleeding, any hematosis on trivial injury, which can be seen in hemophilia. If there is any bleeding parietal in which can occur in HSP and sickle cell anemia. So in sickle cell anemia, joint pain occur because the sickle shaped red blood cell block the blood flow through the tiny vessel to the joint. So that's why the patient might have joint pain. So for extra-articular features, it's also important because most of the diseases are systemic. So you need to cover all the system. So as for diarrhea, referral discharge, ocular symptom, rashes, chest pain, and dyspnea. Okay, next. For family history, as I mentioned previously, some of the diseases are due to genetics. So as for any family history of IBD, psoriasis, ankylosing spondylitis, hemophilia, malignancy, and so on. Okay, so for physical examination, next. First, we need to examine locally at the joint first. So through a look, feel, and move. So first one, look at the gait, if there's any abnormality, if there's any skin changes at the joint, okay? And then feel, you palpate and see for the temperature, if it is warm, tender, or if there's any crepitation. And then move, look at the joint on passive and active movement. And then assess the joint above and below as well, and any check for the neurovascular status of the joint as well. Okay, next. So these are some of the extra-articular signs that you need to look for when patient come with arthritis. So it's too much. You need to cover all system. Okay, so I think you can read this by yourself and memorize. Next. Okay, so for investigation, so I've divided it into blood, imaging, and advanced or invasive. So for blood investigation, we can do a full blood count and check for the white cell count. If it's increased, then it's a sign of infection. And then renal profile, because the kidney can be involved in Kawasaki, in GIA, and as well as SLE. Liver function test, because of GIA as well can also affect the liver. And you can do acute phase protein is usually increased in inflammatory causes. Blood culture and sensitivity, because you want to rule out any septic arthritis. And then serum creatinine kinase, which usually increase in juvenile dermatomyositis. And then ASOT titer is important for rheumatic fever, coagulation profile as well in hemophilia. And of course, you need to look for autoantibodies. So ANA, anti-double-stranded DNA, anti-CCP, which can be raised in RA, ANCA, rheumatoid factor, HLA-B27. HLA-B27 is usually raised in is usually positive in ankylosing spondylitis. Okay, next. Okay, so for imaging, we can do X-ray of the joint to check for any joint displacement, any bone fracture near the joint, and then ultrasound MRI for any tissue injury or sign of inflammation and so on. We can also do echocardiogram or electromyography. So echocardiogram, for example, in acute rheumatic fever, some may have congenital abnormality of the heart, and then electrobiography can be done for juvenile dermatomyositis. Okay, so for invasive, we can do muscle biopsy. Muscle biopsy is actually diagnostic for juvenile dermatomyositis, and we can do joint aspiration and send for cell count and differential, gram stain, check for the glucose, protein, and also as well as microbiology. This is to check for any septic arthritis and so on. Okay. So for the management of joint pain, it's mainly on pharmacotherapy. So we can give NSAID, which is anti-inflammatory, and DMARDs. So DMARDs is divided into non-biologics and biologics. So for non-biologics, we have methotrexate, hydrochloroquine, and sulfasalazine. For biologic is etanercept, anakinra. Okay, and then we also have we can also give steroid, glucocorticoid, and then intra-articular corticosteroid injection, which is usually given during acute situation. Okay, if there is any presence of infection, then we can administer antibiotic, and in case of malignancy, then we can opt for chemotherapy, radiotherapy, immunotherapy, or surgery. Okay, so for non-pharmacotherapy, because usually most of these diseases, usually the joint pain is accompanied by a systemic system, right? So you need to refer the patient. Wait, is the slide moving? Mine is still stuck. Okay. We need to refer the patient to physiotherapy. This is to improve and maintain the range of motion, help strengthen the muscle, and improve endurance of the patient. And also refer the patient to occupational therapy, in which they can do splinting to reduce the pain if this is done if necessary. And to improve quality of life, they can provide adaptive aids and modification of environment. And also refer to ophthalmology for uveitis screening. This is in the case of JIA. Okay, and then refer to dietitian. This is to ensure well-balanced healthy diet for growth. Okay, so next. So I've listed 3 overview of some diseases in pediatric who join pain. According to Sunflower 5th edition, reactive arthritis is the most commonest one, but when I Google it, it's mostly JIE. Okay, so in reactive arthritis, there is a transient joint swelling of less than 6 weeks, and it usually involves the ankles or knees, and it usually follows extra-articular infections such as enteric bacteria, including Salmonella, Shigella, Campylobacter, Yersinia. It is less commonly due to viral infection, which is STD, such as Chlamydia or Gonococcus. And patient will present with low-grade fever, and for this disease, patient usually is treated with NSAID for the joint pain. Okay, so next. Second one is the septic arthritis, which is commonly in less than 2 years old. It is due to hematogenous spread, usually due to adjacent osteomyelitis. It can also be due to puncture wound, infected skin lesion, and usually only one joint is involved. And the most commonest organism is Staph aureus. HIV can also cause septic arthritis, and it usually affect multiple sites. So this is why it's important to ask for the immunization status of the patient. And then for investigation, we can do full blood count. You will see increased white blood cell, and acute phase reactants will also increase. Ultrasound, MRI, and joint fluid aspiration can also be done. And this is treated with prolonged course of antibiotic. Okay, so lastly, we have JIA. Next. So to diagnose JIA, it requires the presence of definite arthritis of unknown etiology, and the onset must be before the age of 16 years old, and it must persist for at least 6 weeks. And because there is no lab test or combination of tests that can confirm the diagnosis of JIA. Okay, and you need to remember that JIA is a diagnosis of exclusion. So you need to rule out everything else first. Okay, so the symptom and sign of JIA, as you can see in the box, there is articular and extra-articular involvement. So for the articular, is mainly all the arthritis symptoms, swelling, pain, joint stiffness, joint warmth, restricted joint movement, and limping gait. For extraarticular, it involves all the other system. You can read this later. Next. Okay, so the management of GRA can be divided into three. When it involves only one, only oligoarthritis or polyarthritis, and lastly when it is a systemic onset JIA. So basically the management for oligoarthritis is start with NSAID or intraarticular corticosteroid injection, and then if it improve on NSAID, then you just continue. If it doesn't, then you can either optimize or change the NSAID, and if it still doesn't improve, then you can give DMARD, and then if it still doesn't DMARD was given orally. If it still doesn't improve, then you can give subcutaneous methotrexate. Okay, so next for the polyarthritis is quite similar. You start with NSAID, and you also start on DMARDs right away, oral methotrexate, and then steroid also you need to give. And if there's improve, if the patient improve, then you just continue NSAID for 6 months, and you need to continue DMARD for at least 1 year after onset of remission, and you need to stop the steroid and NSAID after that. Okay, if it doesn't improve, then you can optimize the dose of DMARD. If there is still persistent, then you need to change to subcutaneous methotrexate. And you can also consider other alternative DMARDs or consider the biologics DMARD. The next, for systemic onset JIA. Okay, so similar. It's actually just similar. You just give NSAID, steroid, and then if it's improve on steroid, then you just stop. You taper down the steroid, and then if it still persists, then you need to give oral methotrexate. And then if it still persists, then you look at the symptom. What if it only involves the arthritis? If it's still systemic symptom or both still present. So if it only involves arthritis, then you change to subcutaneous methotrexate. If there is systemic symptom, you give steroid. If there is a presence of both, then you combine the treatment. That's all from me. Thank you. Any question?
Any questions? You guys dah balik sini belum? Or you guys still at home? Still at home, or some already here?
Some already here, about 10 people.
Oh.
We saw you in the ward today, doctor.
Is it?
Yeah.
You guys 5th year kan?
Yes.
I thought 3rd year je kat ward.
Oh, tadi third year yang duduk kat sofa, kita yang duduk kat komputer.
Oh, okay. Okay, any questions? Any? Actually, one of the differential kan, that is still relatively common lah. Is vitamin C deficient. Scurvy. You can get scurvy come with joint contracture lah. Usually they come with joint contracture, but can easily miss or misinterpreted as arthritis.
Doctor, my ask is JE still common?
I never seen one. In my whole career, I never seen one. It's common in a way. It's common in the center where rheumatologists are lah. Contoh kalau you pergi KL ada lah banyak. Because usually, we don't wait until 6 weeks. The problem with GIA is you need to wait for 6 weeks baru you diagnose. Most of the time, most patient come quite early lah. At latest pun dia akan datang dalam 3 weeks, ataupun 2 weeks, 3 weeks. Because you have to remember lah, GIA kan, the fever is persistent tau. Just imagine lah, you've got a child kan, yang even 12 tahun, 13 tahun punya child, got fever for 2 weeks non-stop. Malam demam, malam demam, malam demam. And then bila demam, ada joint pain, demam, joint pain, demam, joint pain. So chances are dia mesti come to hospital, betul tak? So usually by the time they come to hospital, they already like 2 weeks in the disease lah. And then after 2 weeks, you investigate, you try, you attempt multiple drugs, antibiotics. So total 4 weeks. So you already suspect this must be something rheumatology in origin. So usually by 1 month, they end up dekat Selayang dah. Our rheumatology center lah for pediatric is in Selayang. Okay, we've got rheumatologists in Selayang, I think in Penang and Ipoh. I think these are the only place where you've got rheumatologists lah. So usually by 1 month of illness, dia dah dekat Selayang. So we cannot diagnose GIA. Only rheumatologists diagnose GIA. So the patient maybe the patient are actually GIA lah, tapi we won't diagnose GIA because you don't wait for 6 weeks before you refer to rheumatologist. Faham tak?
Okay.
So I can't really tell you whether this is common or not. I mean, in the literature, it's not that uncommon, but I never seen one at all.
Okay, doktor. So
Recent,
yang paling banyak doktor jumpa joint pain, septic
paling banyak lah, paling banyak kalau pediatric joint pain, paling banyak of course reactive arthritis lah.
Okay.
But reactive arthritis is not infection tau. You don't treat reactive arthritis with antibiotic. Reactive arthritis is actually sequela of infection. It can be caused by gonorrhea, it can be caused by the common infection, Staph aureus, strep pneumonia. This can cause reactive arthritis. It's a sequela, immune mediated lah. Usually it's immune mediated, similar to like rheumatic fever, things like that lah.
Okay.
But it's self-limiting. That's the most common. Then the second most common would be connective tissue disease macam systemic like vasculitis ataupun cancer, malignancy like leukemia. Tapi leukemia, actually if you take a thorough history, proper examination, leukemia they come with bone pain rather than joint pain. Because it is because expansion of the marrow tau. Leukemia, the pain is because of expansion of the marrow. Hyperactive marrow. It's not because of, and you don't have marrow in your joint. So you don't get joint pain lah. But sometimes it can be very distal or proximal, near to the, what you call it? Not peristeum, near to the metaphyseal. So you can get features like similar to joint pain. But again, it's difficult to be sure that this is bone pain rather than joint pain, because leukemia most of the time they come at the young age, like 2-3 years old, where most of the time it's very difficult to examine lah. Exactly, I have a phone call. Assalamualaikum. Okay guys, boleh proceed lah. But I'm expecting a phone call lah, so maybe I akan interrupt sikit. Tapi start lah.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Sarah and we will continue our today's discussion on the approach for child with prolonged unexplained fever. Okay, so next. All right, so fever of unknown origin, or FUO, based on Nelson Essential Pediatrics of 7 edition, stated that temperature of more than 38 degrees Celsius, more accurately is the rectal temperature, lasting for more than 14 days without an obvious cause, despite complete history, physical examination, and routine screening lab evaluation. Okay, next. So there are 4 subtypes of FUO, and for all the subtypes, the temperature must be more than 38 degrees Celsius, but the difference is just the duration. So the first subtype is the classic FUO, in which the duration is more than 3 weeks for outpatient and more than 1 week for inpatient, and commonly because of cancer, infection, or inflammatory conditions. Okay, and then the next one is the healthcare associated, in which it takes shorter duration. So there more than 1 week for outpatient and more than 1 day for inpatient. But the key point here is that the patient must have no fever on admission. Okay, next is the immune deficient FUO, in which it has the same duration as the healthcare associated, but the key point is that there is negative culture after 48 hours. And the usual cause is because the patient is on chemotherapy or immunosuppressive drugs. Okay, and then the next one is the HIV related, in which the duration is similar to the classic, but the patient have underlying HIV. Okay, next. So it is called FUO because we do not know the cause yet. So we have to find the underlying etiology. And the common one is due to infection, in which it accounts more than 50% of the case. Next is the connective tissue disease, such as GIAs, SLE, and then neoplastic disorders such as leukemia and others. All right, so next. Okay, so as I said before, there are many causes of FUO, right? And we can divide them into infectious and also non-infectious. So this slide shows some of the example for infectious, and then the next slide is the non-infectious. So you can go through the slide later. Okay, so we move on to the approach. Next slide. All right. So we move on to the approach on how to approach a patient when they come to us. So of course, we have to take complete history, perform physical examination, and do related investigation. So first for the history, okay, we have to dig further about the fever itself. So we asked about the characteristic of the fever, what is the onset, frequency, the duration, is it responsive or non-responsive to the treatment, and if there's any associated symptoms, which we'll discuss this later. Okay, and then we have to know the age of the patient because it accounts for different common diseases. Okay, next. So we have to know the pattern of the fever because different pattern symbolize different disease. Okay, so for the first picture, there is the continuous fever in which you can see the fever does not touch the baseline and commonly due to pneumonia. And then the next one on the right is the intermittent fever, in which the fever, it touches the baseline, but only for a few hours. And this one is commonly due to malaria. Okay, and then the third one, remitting fever, in which you can see there is fluctuation more than 1 degree Celsius, and it never touched the baseline. So commonly because of IE. Okay, the fourth one down there, on the left is the Polyethylene fever, commonly associated with Hodgkin lymphoma, and you can see the fever lasted for about 3 to 10 days and followed by phase of afebrile. Okay, and the last picture is the step ladder, which you can see there is continuous rising of the fever, gradually increases, just like a ladder, right? And commonly, this is due to typhoid fever. Right, next. Okay, so since there are lots of possible etiology, so we have to inquire on the associated symptoms to narrow down our diagnosis. Okay, so we have to inquire, we ask the patient or the mother if there is any red eyes which can caused by Kawasaki disease, infection mononucleosis, leptospirosis, and then inquire if there's any nasal discharge or stuffy nose because of rhinosinusitis, and then to the head, if there's a neurological problem because patient with meningitis can present with fever, and also have to rule out any neurological deficit. Okay, and then if there's associated with cough or pleuritic chest pain because pneumonia can present with prolonged fever as well. Okay, and then for the GI, we ask for any GI symptoms which can indicate for salmonellosis, leptospirosis, IBD. Okay, and then for night sweat, because in TB and lymphoma can also present night sweat. Okay, and then for urinary, we ask if there's any dysuria, frequency, and hematuria. And for baby or infant, we can ask the mother if she's crying during urinate. Okay, this might indicate UTI. And then if there's any limb or bone pain indicates, or joint pain indicates leukemia or septic arthritis. Okay. And then for rashes, either skin rash, such as mala rash, can indicate SLE. Okay. So next. Okay, so to be systematic, so we just follow the template that we use to plug our patient normally. So we ask for the past medical and surgical, we ask if there's any history of unusual, severe, or chronic infection, because patient of immunocompromised can present with these symptoms, or patient is on any immunosuppressive therapy. And then also we ask if there's any recent dental procedure, because it associated with infective endocarditis. And then for the drug, if there's any inappropriate use of over-the-counter drug, okay, and then any use of eye drops, because it can cause atropine-induced fever or hypothermia. Okay, and then for birth history, we ask if there's any maternal infections during the delivery. And then for nutritional, basically we want to ask about the ingestion of the dirt or the soil, because it was associated with toxoplasmosis. Okay, and then for immunization, if they are completely immunized. And then for developmental, any delay in milestone, because if patient with HIV can impair the neurological and therefore impair the developmental milestone. And then for family history, basically want to ask if there's any similar illness among the family members. We may associate with TB or any malignancy. Okay, and then personal or social history, because especially want to ask if there's any exposure to animals, and also if there's any sick contact, such as patient with TB. Okay, next we move on to the physical examination. Next. All right, so first we inspect for the skin itself. So we look for if there's any palpable purpurate lesion, which may indicate the polyarthritis nodosa, if any malar rash, such as in SLE, or erythema nodosum in IBD, or also SLE. And then next, also for the skin, we can inspect if there's any Rocky Mountain spotted fever rash, any eschar, or for the typhoid fever, if there's any rose spots noted. Okay, and then next slide. Okay, so for the eye, because patient might complain with red eye, right? So we have to clarify what does it mean by the red eye? So it can either be bulbar conjunctivitis, like in the first picture, which indicates in the Kawasaki or leptospirosis. And then if it's in the palpebral, so it may indicate the measles infections or infection mononucleosis. And then if there's any conjunctival hemorrhage, so indicates IE, or CMV, we can see there's chorioretinitis, or in SLE, we can see there's uveitis. You can see the red. Okay, and then we move on to the mouth, to the oral. So we look for any gum hypertrophy, which indicates in the in the acute leukemia. Okay, also for the tongue and also the oral mucosa, we look for the oral hygiene, which indicates in the IE, or any oral thrush, which we can see in HIV patient because of immunodeficiency. Okay, and then we also have to look to examine other systems. So for the cardiovascular, we look for any murmurs for IE, and then respiratory. For respiratory, we look for any signs of consolidation, which may indicate there's pneumonia. And then for abdominal, we palpate for any mass, hepatomegaly, And then for musculoskeletal, we look for any joint swelling or tenderness, may indicate osteomyelitis, JIA, or SLE. And then for CNS itself, we look for any signs of meningism. Okay, next for the investigation. Okay, so we do basic tests for all patients. So first we can do a full blood count. So basically we can look for leukocytosis because we want to identify if it's due to infection or not. So there is increase in white blood cell if there's bacterial infection, and also increase in in platelets if there's a severe bacterial infection, and then look for any anemia for patient in malaria, TB, IE, and so on. Okay, and then we also look for inflammatory markers such as ESR, CRP. So we look for any raise in ESR if there is more than 30 millimeter per hour. So may indicate inflammation. If there is more than 100, which may suggest TB, Kawasaki, malignancy, or any autoimmune disease. Okay, and then we can also do the blood culture and sensitivity, and also the urine culture and sensitivity to rule out any infectious cause. Okay, next, we also do investigation that, and the investigation must tally to our history and physical examination. So we can do, if we suspect for infection, we can do a chest X-ray, which may indicate pneumonia. And then if suspect malignancy, you can do the CT or MRI scan. Okay, and then if we suspect for any neurological problem, so we do lumbar punctures for CSF analysis and also culture. Okay, and then if we suspect there's any leukemia, so we do the bone marrow aspiration. Okay, and if we suspect for autoimmune disease such as SLE or GIE, we can do the surgical test. Okay, so next is the management. So basically this is the principle of management. So we treat the underlying cause, and then we have to continuously monitor the patient. And then if patient is on any non-essential medication, we have to discontinue medication. And then we have to treat the fever by giving the antipyretic. Okay, and then for antibiotic treatment, we have to note that we only give if there's evidence of infection to the patient. Okay, and also we have to give supportive therapy such as for hydration and so for nutrition. Okay, and next for the prognosis. Okay, so generally, children has better prognosis compared to adults, and 25% of children, the cause remain unclear even after we thoroughly evaluate them. Okay, and in many cases, no diagnosis can be established, and some might reduce spontaneously. Okay, next is all my references. Is there any question?
Yeah, any questions? Any questions?
Doctor, I have question, but it's not regarding to PUI. Doktor, boleh terangkan tak apa beza sebenarnya serum osmolarity dengan osmolality, doktor? Sebab cari kat internet, yang satu tu kata 1 per liter solvent, satu lagi kata 1 per kilogram solvent. Sama je unit dia kan? 1000 lah maksud saya. So macam dia nak cakap apa?
Sama lah.
Oh tak sama eh?
Itulah
Okay,
beza
doktor
dia.
terangkan boleh? Beza dia. Alamak.
Okay, okay. Cuba mention tadi apa beza dia?
Yang tak silap saya, serum osmolarity yang 1 per liter solvent. Osmolarity yang 1 per kilogram solvent.
Apa? Susis apa? Sorry, apa dia ulang balik? Osmolarity apa?
Dengan osmolality. Kalau yang riti 1 kilogram per solvent. Tapi kalau yang osmolality 1 liter per solvent kot. Ke satu balik. Tapi saya tahu nombor dia 1 kilo dengan 1 liter. So macam dia nak cakap apa sebenarnya, doktor?
Okay, dia osmolarity, dia volume tau. Dia guna volume per liter.
Tu kalau osmolar.
Osmolarity. Kalau osmolality, dia mass, which is kilogram per mole, kilogram per liter.
Sebab kan doktor macam in pediatric kan ada macam kes kan diabetic insipidus kan doktor. So dia cakap macam mana kita nak bezakan cranial DI dengan nephro DI tu kita buat serum osmolality test.
Betul.
Tapi
Itu
macam
DI kan? Bukannya diabetes.
DI diabetic insipidus.
Okay lah. Okay, DM.
So-
Okay. Pasal?
So macam saya terfikirlah apa benda dia nak cakap tu, apa yang dia masukkan dengan osmolality dengan osmolarity. Macam kalau dalam exam kita dapat soalan dia kata this patient osmolarity is normal. So dia bukan nak hint kita ke arah DI kan doktor? Ke saya yang macam tu?
Macam mana? I pun dah confused. Macam ni yang DI yang cakap tadi?
Okay, tadi kan macam diabetic insipidus. Contoh, saya minta maaf kan dari topik sebab tadi doktor ada sebut
tak apa,
perkataan
it's okay.
osmolarity dengan
Betul.
osmolar. So
This is
saya
very
nak
important.
tahu. So tadi macam saya baca diabetic insipidus, dia ada cranial DI dengan nephro DI. Jadi further reading saya baca tu dia kata untuk kita bezakan sama ada ni nephro ataupun cranial, kita buat osmolality test, serum osmolality test. Jadi saya terfikirlah contoh kan PMP kita dapat soalan, nanti kan macam trigger 1 dia bagi hint apa, trigger 2 lah investigation kan. Contohlah dalam investigation tu dia bagi tahu saya this patient serum osmolarity is normal. So dia ni nak bagi tahu saya yang saya dah boleh rule outkan diabetes insipidus ke? Sedangkan yang dalam buku tu DI ialah osmolality.
Sekejap, saya ada phone call. Sekejap.
Boleh.
Okay. Okay lah. Okay. Actually, we don't use osmolarity because osmolarity is a macam ni. It's very it's very difficult question. But osmolarity ni dia measure macam ni nak cakap. Osmolality dia measure the concentration in volume of blood.
Concentration in blood. Okay.
Kalau osmolarity macam ni
Yang dia cakap dekat internet kan doktor, dia kata number of solute particle per 1 liter solvent.
yang tu for osmolarity. R kan?
Kalau yang L dia kata solute particle 1 kilo per solvent.
Sebab is more or less the same. Semua cuma to be honest, I pun tak sure sangat. Tapi in general lah, we don't calculate osmolarity in clinical practice kan. Osmolarity ni yang kita belajar waktu sekolah tu, faham tak? Mol per liter. Mol. Dan kita kena mol kan. Tapi osmolarity, kalau osmolality is what matter lah. In clinical, osmolality yang kita measure.
Okay doktor. So keyword dia kalau misalnya jadi sepatutnya dia akan cakap pasal urine osmolality lah.
Yes, osmolality. Yes, osmolality. The same thing yang contribute to both osmolarity and osmolality contributed by the things lah, by dextrose, sugar level, urea and also sodium. Cuma osmolality ni dia different because it's measuring per kilo per mole.
Per kilo per mole.
So it's concentration of the solute per volume of blood. Macam tu.
Jadi doktor cerita pendek dia dalam, saya minta maaf doktor. Jadi dalam exam kan, keyword dia diabetic insipidus memang osmolality lah. Kalau misalnya dia kata this patient urine osmolality if insignificant, contoh. So nak cakap sebenarnya ni tak ada kaitan dengan diabetic insipidus lah kan, contoh.
Susah sikit macam ni. Contoh in diabetes insipidus kan,
Saya
what would you expect the osmolality of serum?
serum urine osmolality dia depend dekat tempat mana patologi dia doktor. Yang saya faham kalau orang tu dekat cranial DI, urine osmolality dia akan tinggi. Tapi kalau nephro DI, urine osmolality dia akan rendah sebab dia tak boleh malfunctioning of the ADH.
That's not right actually.
That's not right. Alamak doktor.
Okay, DI ni apa DI?
Diabetic insipidus. Dia
Okay,
ialah
what
bila urine
Exactly.
yang dihasilkan.
How you diagnose diabetes insipidus?
Yang saya faham kita
Forget
diagnose
about the
diabetes-
nephrogenic or central DI. How do you diagnose diabetes insipidus?
kita pakai desmopressin test doktor.
Tak adalah. You don't need the small person test to diagnose. Okay. How do you diagnose DI? In clinical lah. You don't do the small person
Saya
test
cuba lagi satu.
Okay,
Kalau doktor kata bukan desmopressin, adakah kita suruh patient ni withholdkan fluid dia dulu, lepas tu baru kita weightkan patient tu frequently, dan kalau patient tu tak boleh kurangkan urine output dia and the urine is not concentrate, it is a diagnostic, is it?
Tak payah pun. You just check the osmolality je. You just check urine osmolality.
Okay,
You don't do
doktor.
that lah. Yang tu you buat kalau macam SIDH je. SIDH you restrict fluid in
Faham, doktor.
SIDH. Tapi in DI kan you just ambil dia punya urine osmolality ataupun urine SG.
Okay, dapat.
Okay, you in DI, DI is diabetes. Nama diabetes means you kencing lah. Diabetes is kelab kencing. Insipidus ni like cair lah. So I kencing you cair. It's very diluted urine. Okay. Both central and nephrogenic DI, you will produce diluted urine.
Betul doktor.
Okay, because pathology dia dekat ADH. Cuma the difference is in central DI, ADH tu tak ada. Faham tak?
ADH tu rendah.
Dia rendah ataupun tak ada lah. In DI, in central DI, ADH tak ada. Because brain you rosak, the pituitary rosak, so pituitary cannot produce, the hypothalamus rosak, so cannot produce ADH. Okay.
Faham doktor.
Okay, pathology kat central. In nephrogenic DI, same thing juga. You still produce diluted urine, tapi bukan sebab ADH tak ada. ADH tu not working.
Dia disebabkan
Because
renal yang
receptor tak ada.
masalah kan doktor?
Receptor tak ada.
Receptor yang tak ada. Okay, faham?
So in nak bezakan dia tu, you just check the ADH level.
Check ADH level.
Yes, you measure the ADH level. Kalau you confirm, okay, patient ni ada DI, you confirm patient ni ada DI, urine very diluted, compare dengan dia punya serum osmolality. Kan, dia very diluted urine. So you ambil ADH level, ADH high. So you rasa problem dia kat mana?
ADH high, problem dia dekat nephro lah.
Kat kidney lah kan? Tapi kalau ADH dia low, problem kat mana? Problem dia?
Dekat central doktor.
Kat central. So senang je, macam tu ada diagnosis dia.
Jadi saya tengok urine osmolality dengan dalam pediatric kita tengok urine osmolality dengan ADH.
Kita urine dia macam ni. Kalau you in general lah 90% of time DI is caused by central. It's very rare. Nephrogenic DI is quite rare. It's quite rare. So usually lah kalau you akan treat as nephrogenic DI, tapi bila you bagi ADH tak works. You akan treat as central DI. And then bila you bagi ADH tak works, then only you suspect this is nephrogenic DI.
Okay doktor.
Okay.
So itu yang pertama doktor ajar tadi pasal investigation mana yang nak pakai macam nak diagnose. Lepas tu yang kedua tadi doktor ajar yang antara clinical usage kita lagi pakai osmolar lah, L daripada R kan doktor?
Yes. Kita tak guna osmolarity. Osmolarity ni guna dalam kimia kita belajar, kita guna lah. Atau dalam calculation ubat kita guna. Tapi kalau blood kita guna, clinical kita guna osmolality.
Okay doktor, faham. Terima kasih doktor.
Okay, faham. Okay, next. Soalan.
Doktor, Assalamualaikum.
Waalaikumsalam.
Doktor, saya punya soalan pun tak berkait dengan topik, tak apa ke?
Tak apa je, okey je.
Doktor, kalau macam in child with heart failure, datang chronic anemia, datang dengan failure symptoms, tapi dia tak overload, kita akan bagi anti-failure medication tak? After dah resus, dah bagi blood.
Kita bagi apa? Kita bagi apa?
Anti-failure medication.
What do you mean anti-failure medication?
Anti-failure macam diuretics.
Is diuretics anti-failure?
Dalam PIPS protocol dia cakap anti-failure. Bukan ke?
That's a problem tau. That's a problem.
Okay.
That's why bila kita guna drugs kan, use the proper class lah. Kalau you pakai anti-failure kan, cardiologist, kalau you cakap pediatric cardiologist, kan, cakap pediatric cardiologist, memang ada kata anti-failure is because most pediatric pathology is because of fluid overload rather than problem with cardiomyopathy kan, outputnya problem ataupun high outputnya heart failure. Tapi in the case of high output cardiac failure, contoh macam thyrotoxicosis ataupun anemia kan, severe anemia causing in severe
High
anemia
output.
is a high output because heart kan kena pump lama dia penat, dia mati. Faham tak? So it's a type of high output cardiac failure. So kalau you bagi dia anti failure, okay, it works. It works at the symptoms level. It reduces the symptoms. Tapi patient still akan dapat failure symptoms, still akan ada heart failure symptoms. Sebab in this kind of case, contoh for example macam dilated cardiomyopathy, patient with cardiomyopathy lah, dilated cardiomyopathy ataupun cardiomyopathy secondary to thyrotoxicosis kan. This kind of case atau viral myocarditis causing cardiomyopathy, kalau you bagi anti-failure, it can worsen the problem. Why? What is the side effect? In what case you bagi fluid, you bagi diuretics? Overload kan? Kenapa you bagi diuretics?
Sebab
you nak buang darah dia, betul tak? Nak buang fluid kan? Nak
buang fluid.
You nak reduce the volume kan? What happen bila you reduce the volume? BP dia drop, betul tak?
Betul.
Kan? So what happen kalau you ada heart yang weak, okay, heart yang weak, okay, and then you buang air, you dropkan BP dia. You rasa apa akan jadi? Dia kerja lagi keras lah kan? Faham tak? Sebab dia bukannya problem dengan, you tak constrict dia punya peripheral resistance. Tapi you buang air, you bagi diuretics, BP dia drop, kerja dia lagi banyak lah. So, dia kena push, dia kena maintain normal BP. On top of that, fluid dah tak cukup. Faham tak? So, the management in this kind of case, you kena bagi things yang chronotropic ataupun yang inotropic lah, the best. Inotropic, chronotropic. So, you kena bagi things yang kuatkan dia punya pumping.
Heart contraction.
Pumping. So, you bagi benda macam mana? For example, you bagi digoxin. Faham tak?
Okay.
You bagi digoxin. Ataupun in some cases, you bagi beta blocker untuk relaxkan heart dia sikit. Faham? You dah bagi dia blood. Of course, you kena bagi blood lah. Kalau you tak bagi blood, dia mati lah. You buat apa benda pun. Kalau patient ni heart failure secondary to anemia kan, because anemia, high cardiac output, heart failure, you tak bagi blood, you bagilah apa-apa ubat pun dia mati lah at the end. So you dah bagi blood, okay, you dah bagi blood, okay, you reverse the pathology, and now to help the heart, you bagi things macam beta blocker to relax the heart a bit,
so
and then you bagi digoxin. Okay, faham tak?
Faham? More on inotropic or chronotropic effect lah. Dia punya.
So that's why you can understand the pathology. Sama macam adults, diuretics is not the main treatment untuk adult heart failure. Adult heart failure apa you bagi?
Apa
Apa heart failure punya medication in the dark?
Beta blocker.
Dia bagi beta blocker kan. Because heart problem dia ialah majority of the heart problem, heart failure in the dark is caused by cardiomyopathy, either diabetic cardiomyopathy, hypertrophic cardiomyopathy secondary to hypertension, ataupun dilated cardiomyopathy secondary hypertension. Faham tak? Tapi in pediatrics, heart failure is usually caused by loading tau, fluid loading, fluid overload. Secondary tu structural defect. Faham tak? The heart is very good. The pumping of the heart, there's no problem. Budak kan dia macam innocent, dia bukannya isap rokok, bukan ada diabetes. So the heart is normal. The muscular is normal. But the problem with the pumping failure due to fluid overload. For example macam VSD. Dia ada double volume untuk heart pump. Kan? So dia tak sempat nak pump, fluid dah accumulate dekat lung. Because dia ada double output kan to the lung. Ataupun in PDA, in fact kalau patient with rheumatic heart disease pun, problem is with the valve. Tapi heart dia still okay. Tapi now the heart has to work double. Kan? Dia pump darah keluar and then you ada contoh ada AR kan. So dia masuk balik dalam into your left ventricle. And then left ventricle now receive blood that backflow from the aorta into the left ventricle and also blood from right ventricle to the left ventricle. So dia double volume pumping. Even though dia normal, dia very good pumping, but eventually dia akan jadi tired, dia akan perlu double work lah. Okay, faham tak?
Faham,
Faham kan?
Faham.
Okay. Itu
Okay,
soalan.
thank you.
Doktor, saya ada soalan. Ini tak related to Sumina juga. Kalau baby with RDS kan, is there any role of blood transfusion untuk increase the oxygenation?
Untuk patient apa? RDS?
RDS,
Baby RDS kan? Okay, in general kan, we treat based on pathology lah. Apa problem dengan RDS?
Surfactant immature.
Dia ke immature?
No, surfactant with low surfactant
Deficient lah kan? You the surfactant deficient. So macam mana dengan bagi blood transfusion you improve surfactant deficient?
Macam tak ada.
So tak ada kan? In fact, sometimes it can be counterproductive lah. In lung pathology kan, we want the lung to be as dry as possible. Because water is not good for the lung. Water should not be present in the lung. Dia kena ada sikit lah. Because when you've got too much blood and too much water will seeps out. Okay, they seeps out through the capillary and they wet you punya lung. What happen bila you wet lung? You akan suffocate. You dapat failure symptoms lah. All these failure symptoms is because wet lung. Okay, pulmonary edema. Okay, because vessel dilated kan, causing capillary leakage that wet your lung. So you dapat pulmonary edema. So usually in lung pathology, we want the fluid as minimal as possible. That's why kalau you ada lung patient with lung punya problem, you restrict fluid. Okay, you restrict fluid. Even in patient with BPD, in chronic lung disease, the mainstream of treatment is actually fluid restriction, thiazide diuretics to dry up the lung. Okay. Tapi however, you have to remember, in patient that require ventilation, you need the carrying capacity to deliver oxygen. Faham tak? Contohlah, kalau patient ni dah lah tachypneic, they require support for oxygen, and then they anemic. So what happen? Dia kena work harder kan? The heart works harder, needs to work harder to pump blood to the lung to get it oxygenated, kan? Because now, like RDS, part of the lung is not functioning lah, because all the periphery of the lung, the VQ, there's VQ mismatch kan? So the lung itself tak efficient, so the heart need to work harder to pump more blood to the lung, and also to increase the VQ by increasing the frequency of respiratory and also the heart lah. And then now there's not enough carrying capacity, blood carrying capacity, oxygen carrying capacity in the blood due to the lack of hemoglobin. So it's counterproductive. Okay, so patient with that require ventilatory support, you aim higher oxygen, you aim at higher BP, higher HB, sorry. So for example, if patient HFO, you want the HB at least 13 to 15. Less support, for example, like patient with on CPAP kan, on CPAP ke BiPAP, you may need more than 11 or 12. Tapi patient on room air, 10 is sufficient. You faham tak?
Faham tak?
So don't get misconception. Blood transfusion is not the treatment for RDS.
Okay, thank you, Doktor.
Okay. Okay kan?
Doktor, saya ada satu question juga.
Ya,
Lari juga dari topik, tapi kalau patient budak-budak datang dengan, contoh datang asma, severe asma, lepas tu kita buat ABG datang dengan mixed respiratory metabolic acidosis. Adakah manajemen dia lain daripada metabolic acidosis yang biasa? Maksudnya kita kena intubate ke patient tu sebab saya tak sure bahagian tu.
Okay. Bila you decide untuk intubate?
Kalau refer slide tadi, kalau yang previous tadi, kalau SpO2 less than 92, even with high flow mass oxygen ataupun low conscious level.
Okay, first kan, first you have to remember lah, you not necessarily intubate because of lung pathology, okay? Neuro punya pathology you have to intubate lah. Kalau reduce breathing effort, okay, you are anticipating ventilatory collapse due to airway punya protection. Contoh kalau patient collapse kan, neurologically dia collapse, dia unconscious, dia tak boleh protect airway. So you need to protect the airway by intubation. So despite patient with cerebral edema kan datang dengan encephalopathy, you may need to intubate walaupun you need SpO2 100. Remember, but that decision because of to protect the airway. Because airway is number one, A number one, B is breathing. Respiratory comes second from airway. Can remember tau. Okay, tapi in patient with lung punya pathology, you will intubate kalau patient hypoxic. Faham tak? So you will be guided by SpO2, by PaO2 or even PCO2. Okay. Okay. Usually like in general, PCO2 reflects your ventilation. PO2 reflects your oxygenation. You ada type 1, type 2 respiratory failure kan? So in patient with asthma, can they get metabolic acidosis?
Boleh.
Apa yang cause metabolic acidosis?
Asthma.
When we say metabolic acidosis, apa maksud dia?
Bicap dia rendah.
Okay, I nak you bagi, can you give me a number, hypothetical numbers or hypothetical ABG results that reflects both mixed respiratory and metabolic acidosis.
Contoh kalau patient tu datang dengan pH dia less than 7.35 lah, 7.2.
Okay, 7.2.
And then PCO2 dia high, more than 45, contohnya datang dengan 70.
Okay, PCO2 70, okay, good.
Okay, lepas tu bicap dia rendah, less than 22, contohnya 13.
Okay, bicap 13.
Okay.
So this is a clear mixed respiratory and metabolic acidosis. Okay, very good. But usually this kind of numbers you akan dapat, dia punya pH will be 7.1 lah, the most.
Okay.
Okay. Okay, so in this case, kenapa kita nak ventilate?
Ventilate sebab kita nak buang, ventilate.
Okay, how about the oxygen? How about the oxygen?
Oxygen dia pun rendah.
Berapa?
70.
Okay, so what is your full diagnosis? 70 tak ada last night. 70 on apa ni? Dia on apa? High flow mask.
Sekarang ni dia dah on high flow mask lah. Face
contoh
mask.
dia on, contoh dia on face mask. Okay, PO2 dia berapa?
PO2
70
dia.
tu normal kan? PO2 dia?
PO2 dia 70. PO2 dia.
Okay lah, boleh lah 70. Okay, rendah sikit lah, 50.
Okay.
Okay, so what is your diagnosis? The ABG diagnosis?
Type 2 respiratory failure with mixed, mixed respiratory metabolic acidosis.
It's a type 2 respiratory failure because the hypoxia, respiratory failure, it depends on the level of oxygen. Kan? So dia hypoxia, so you say this is type 2 respiratory failure with mixed respiratory and
metabolic acidosis.
metabolic acidosis. So you nak intubate ke tak?
Saya mungkin
Mungkin.
nak
You seorang the doctor sekarang. You on call.
intubate sebab
Kenapa
dia
you
dah
nak
rendah.
intubate?
Satu sebab tadi oksigen dia terlalu rendah. Lepas tu walaupun dia dah yang high face mask kan, tapi dia still oksigen dia sangat rendah. And then dia
So
pun
maksud dia patient ni, macam mana you expect the condition of this patient at the moment? Kalau I cakap, you RR dia berapa? You rasa lah sekarang ni.
patut RR dia sangatlah rendah. Rendah ke? Tinggi lah. Tinggi lah.
Ya,
Sekejap.
Tinggi doktor.
Kalau tinggi kenapa CO2 dia high?
CO2 dia high.
Aduh.
Pening.
Okay, usually lah kalau you dapat these numbers kan, patient ni dah collapse lah. Atau patient ni dah very tired. Dia punya
Labor breathing ke?
dia very labored but inefficient.
Okay. Dia
Very
labor
shallow.
breathing.
Dia kan dah very shallow, very inefficient, muscles semua dah naik. Dia dah use all the accessory muscles, but dia tak boleh compete with the high CO2. You faham tak? So that's why dapat metabolic cirrhosis. The muscle all tired, lactate dah increasing, dia dah hypoxic kan. Dia dah ada cellular hypoxia. So they start to use all this anaerobic respiration. So dia dah accumulate all this lactate. So dia dapat metabolic acidosis. Faham? So in this kind of case, kalau you tak intubate, kejap lagi dia mati lah.
Okay.
So you mesti intubate. Number one for the hypoxia lah, untuk hypoxia. Second, you nak remove the CO2.
Okay.
Because to remove CO2, you kena ada a good breathing effort. Okay, kalau tak macam you nak remove CO2 kan?
Okay.
So you kena intubate lah.
Okay.
So you need to be clear. Contoh patient ada, you ada patient yang datang dengan DKA. Okay, DKA, severe metabolic acidosis. Tapi your hypoxia tak ada, good oxygenation, SpO2 100%. Severe metabolic acidosis. pH 7.1, 7.0 lah. DKA je you dapat 7.0 ni. Okay, DKA 7.0, even 6.9 lah. 7.0 lah senang, 7.0 pH. Bicap dia single digit, 5. Ni intubate lah macam ni.
Kena.
Kenapa? Kenapa you nak intubate? I tak kata salah. Some people they intubate. You nak intubate tak nak? 7.0 kot pH.
Rendah kan?
Kalau edak dah mati lah. Edak kat 7.0 ni dah mati lama dah. Pediatric je yang boleh survive 7.0. Edak you confirm mati dah lah insyaAllah. Cepat. You nak intubate tak nak? You guys tak ada macam simulation Macam
belum lagi.
Waktu tapi ada lah simulation session.
Rasanya ada kan yang panggil itu apa untuk tapi IM lah.
Megacode. Tapi ada lah I don't
know. So, kita orang tak ada lagi klinik.
Guys tak ada yang patung simulation. Tak best lah guys. Tak ada. Simulation by case lah. Bukannya by Viva macam ni. Bukannya by macam ada patung you kena work in team and then you kena act macam doktor. Tak ada sayang. My undergrad memang best lah. Kita orang ada macam almost weekly or 2 weekly. Kita ada simulation session. Kita ada dummies. And then dummies tu boleh cakap lah. Basically ada orang akan cakap. And then dia ada BP, dia ada heart rate, you boleh masuk line. And then you boleh bagi medication. And then you boleh tengok dia punya, you boleh auscultate dengan heart. Memang cool lah. Then at the end you tahu lah whether you mati ke tak. So this patient, you nak intubate tak?
Nak. Tapi tak tahu kenapa. Sebab rendah 7, sebab severe metabolic cirrhosis.
Yelah, severe metabolic cirrhosis you nak intubate tak?
Nak, tapi tak tahu reason dia. Kawan-kawan tahu tak?
Syuat?
Tak, doktor.
Tak tahulah doktor.
Okay,
Saya rasa intubate.
Okay, first you have to have a good correct mindset lah, okay? You treat patient tau, you bukan treat numbers, you treat patient. Okay. Kalau patient you with this VBG, dia dah koma, you nak intubate tak?
Nak.
So, you
Kena.
sebab dia
Intubate.
koma ke ataupun sebab dia punya metrobacillosis?
Sebab dia koma.
Terus koma lah, you need to protect the airway. Remember, airway number 1, breathing number 2. Okay. So kalau patient dah koma, dah unconscious, obtunded, you mesti intubate. Regardless kalau patient dia normal pun, you kena intubate. Tapi kalau this very bad VBG, tapi patient tu gelak-gelak, okay, SpO2 100%, tak ada risk of aspiration, you takkan intubate kan? Okay, faham tak? So the question is, bila orang tanya you nak intubate ke tak, you treat patient, okay? You don't treat numbers.
Okay.
Okay, faham
Faham?
Okay. Dah, itulah.
Thank you, Doktor.
Okay, welcome. Okay, last soalan. Berat ni kelas 2 jam.
Tak ada.
Okay, tak ada. Okay, good. Okay lah, kita tanggungan. Tasbih kafarah. Okay, dah.
Thank you, Doktor.
Very much, Doctor.
Thank you, Doktor.
Thank you, Doctor.
Thank you, Doktor.
Okay, thank you.
Doktor.
Assalamualaikum.
Thank you, Doktor.
Assalamualaikum.